Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. Today we're going to talk about sleep and hopefully not to bore you to death so that you're falling asleep right now. But if you ever had trouble falling asleep or know someone who has, this is the show for you. To get more information that you may need to be educated or possibly to discuss the potential problems with your own doctor. My guest today is Dr. Barry Krakow, a board-certified internist and sleep medicine specialist who has worked in the field of sleep research and clinical sleep medicine for more than 30 years. Pioneering innovative techniques for the treatment of chronic nightmares, insomnia, sleep apnea, and restless leg syndrome. He is also a professor of psychiatry and behavioral health at Mercer University School of Medicine in Georgia. Dr. Krakow, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Good to be with you. Thanks for having me.
So tell me a little bit more about you and what made you to decide to focus in your career on sleep.
Well, no surprise, I've had a number of sleep issues in my life dating back to my teenage years. And although that was not the direct way I got into it, I believe that divine providence brought me into sleep in the late 1980s. I began working with two psychiatrists in the Department of Psychiatry at the University of New Mexico in Albuquerque, where I used to live. And they were pioneering a technique for the treatment of nightmares. And for the next several years and decades, eventually, I took over that research and expanded it into treating nightmares, insomnia, sleep apnea. And the most remarkable thing about the work was the recognition that sleep problems are almost always mind-body medicine, almost always mental and physical. Somebody might think their sleep problem is psychological, but there's really something physical going. Somebody might see their sleep problem is physical, but there's actually something psychological going on. That's a big, big deal in trying to understand a person's sleep problems.
So can you define for me what is sleep and why does our bodies need it?
It's a great question. In my new book, Life-Saving Sleep, what we talk about is this discovery of what's called the glymphatic system. Everybody knows what a lymphatic system is. But in the brain, there is a glymphatic system, which is actually you'll like this, a brain washing system that goes on in your brain to clear away lots of toxins and waste material so that when you wake up the next day, you have energy, you have good concentration, good memory, but also if this system is not working, you now have a risk for dementia and for depression and for other mental health problems. So now we can say without a doubt that sleep not only restores our energy, but it actually is protecting us and preventing us from having brain damage.
So sleep itself is very restorative, would you say?
That's right. It heals you. It heals you. We think of sleep as a respite. You know, you get that break from reality and that's fine. But really, sleep's more important processes are that it heals you. And that's where you get into the big issue of how good is your sleep? Not how many hours you sleep, but how good is your sleep? What is the quality of your sleep? And throughout my book, Life-Saving Sleep, that's all that we talk about, that you must understand what quality sleep means. Because if you keep focusing on the number of hours, you will miss out on a tremendous opportunity to improve your health.
So I'm not really looking at the number of hours I'm sleeping. I'm looking at the quality. How do I know when I wake up that I experienced during the night a quality sleep? How do I know that?
I love that question because there's so many different possibilities that will help you know that or know that you're not getting good sleep quality. So most good sleepers within a few minutes to 30 minutes, depending upon the age group, will wake up very easily, get started. I like to say they jump in the shower and start singing. And they will actually have tremendous bursts of creativity, noticing they can get a lot of things really well constructed in their mind just in those early morning hours. They go through the day with very limited dips in energy or concentration. A so-called normal sleeper, somebody who has great sleep quality, would almost never be using caffeine. It just wouldn't even occur to them to be using caffeine. They go, what is that? They go through the day. In the evening hours, here's a real telltale. In the evening hours, a very good sleeper is highly unlikely to sit down in front of a television set and watch movies. Something's very passive. They're much more likely to be active and engaged. They're doing hobbies. They're working on their children's homework with them. They're doing something with the community. They're on their neighborhood, softball team, basketball team, whatever it happens to be. And then they get into bed at night and they do this amazing thing. They go to sleep.
Yeah.
And they stay asleep all night. And here's a big one. They don't get up at night to use the bathroom. So that's an example of how a person can say, well, if that's me, then I must have really good quality sleep. And each of the things I mentioned has relevance to pointing out if you don't have that, then there's something that we need to consider about whether you could have poor quality sleep. And I love to talk about the one about trips to the bathroom because people go, what is this guy talking about?
Right.
Like, everybody gets up at night to pee.
Right.
So what do you mean like getting up to pee is like abnormal? Well, if you ask a urologist or an obstetrician or a primary care doctor and you say, well, what's normal? And they'll go, oh, 1 or 2 times is normal. I say, really? That's very interesting. If you treat someone's sleep problems, and I'll get back to the specifics in a moment, you usually will turn that down, especially in this age group we're talking about, younger, middle-aged, individuals. That should go to 0. 0 trips to the bathroom at night when you look at what is actually going on in your sleep that could cause you to wake up and use the bathroom.
Why is it that when you're a baby, it seems as though you are sleeping hours, and as you age, the requirement for the number of hours of sleep seems to dip. You don't require as many hours. Why is that?
There's a bit of confusion about that in that when people make statements like that, the question is, who are we talking about? Are we talking about good sleepers or bad sleepers? Among good sleepers, the dip that you just described would be far less. There'd be many people as they age who are good sleepers, they're still getting relatively similar numbers. It could be 6, it could be 7, it could be 8. They say, no, this is my pattern. I've had it for life. It really hasn't changed. But see, now when you throw in what are called sleep disorders, which is, a lot of what I talk about in the book, you realize as you get older, the sleep disorder is fragmenting your sleep. So when your sleep gets fragmented, that means broken up.
Yeah.
That's, we know it is tossing and turning in one sense. But if your sleep gets broken up, then what's going to happen is your sleep starts getting shorter because you actually wake up from sleep and you can't get back to sleep. And that cycle can continue for years. And you start noticing, well, maybe I don't need as much sleep. And that could be true. Your sleep could drop a little bit.
Right.
But the real question is, why are you waking up? And if we fix that, what will happen to the number of hours of sleep you get? And that's a very, very interesting question because remember, the big issue is quality. That means you can have some people where you fix the quality of their sleep and they'll sleep more hours. You can fix the quality of somebody else's sleep and they'll sleep less hours. And so quality is what counts, just like it does in most things in life. And an examination of quality is the best place to start in trying to understand your own sleep.
So if you can define for me what insomnia is. I know your book talks about this. What is insomnia?
Simple definition is simply you have trouble falling asleep. You could have trouble falling asleep at bedtime. You could have trouble falling asleep in the middle of the night when you wake up. You could have trouble falling asleep in the early morning when you wake up. So it's all about your ability to fall asleep. And the biggest reason people have trouble falling asleep is quite simple. They cannot recruit the biological sleepiness in their brain that says, okay, I'm drowsy, my eyes are heavy, I can sleep. It's a very simple concept. And most people who are insomniacs over time, especially after the age of, say, 40, they'll no longer have any trouble going to sleep at bedtime. But then they wake up, but they can't get back to sleep at night. So it's interesting. You explain to them, well, remember, you fell asleep at bedtime and you were able to feel sleepy. And so then the question becomes, so you woke up at the middle of the night and you were wide awake. This is very common amongst insomniacs. They'll say, yes, that's right. I wake up at 3:00 in the morning and I'm wide awake. That doesn't make any sense. I say, you're right. It doesn't make any sense. And this gets to the heart of a very big issue about sleep fragmentation. Let me ask you, why would somebody wake up in the middle of the night and be wide awake? Remember, most people wake up and do what? They roll over and they go back to sleep.
Right.
But in insomnia, that means those people are sleepy, so they can roll over and go back to sleep. Insomnia patient is wide awake. Any guesses from your own background where you'd say, well, why would somebody wake up and be wide awake?
Could they be in pain? Could it be a pain experience that they're...
Very good. In other words, what we're getting into is the physiology and the physical.
Yeah.
Absolutely, a person with pain could do that. Anything else that comes to mind?
I'm thinking maybe they have maybe an illness. Maybe they have an enlarged prostate and they can't hold their urine and it wakes them up and they have to get up and go to the bathroom.
Very good.
Maybe
all of these
environmental issues,
temperature,
right?
Noise, all that. Okay. But it turns out the biggest one is the shocker. It's most people with insomnia, and we've published multiple papers on this.
Yeah.
And now this is emerging into the scientific literature. Most chronic insomnia patients, people who've had it for several years, some of them have tried pills, some of them have tried psychotherapy. Most of them who don't get a good response to those treatments have sleep apnea. And they never, ever would have expected it. Well, see, this is the perfect explanation. Like, well, what does sleep apnea do? It's choking your airway. So, of course, you're going to wake up. You have a sympathetic discharge. You're wide awake. And yet you don't know that happened.
Right.
You're just sitting there going, I'm wide awake. What happened to me? Well, if somebody could have videotaped you, or done something, 2 minutes earlier, and you watched the inside of your airway collapsing, you go, holy cow, I am suffering a mini suffocation. And my brain is so smart, it says, wake up, wake up,
yeah.
wake up, wake up.
Okay. How do we fix this quality? I know that sleep apnea patients, is there any kind of place that I can go, like a sleep study, to really determine what's going on during my sleep? To diagnosis?
Absolutely. But the field of sleep medicine has become a little bit problematic in this regard because it's sometimes hard to get into a center. Sometimes they won't even do testing in the center anymore. It's only home testing. The home testing is not that good. It's good for people with really obvious sleep apnea. It's not as good for people where it could be mild to moderate sleep apnea. And the important thing to hear is mild to moderate sleep apnea are a big deal. If somebody says you have mild sleep apnea, don't turn around and say, oh, well, they just said I had mild sleep. No. It's a very big deal. Yeah. Mild sleep apnea can lead to high blood pressure.
Oh, yes.
Mild sleep apnea can lead to cardiac arrhythmias. Mild sleep apnea can cause you to wake up at night and have trips to the bathroom. Mild sleep apnea can make you exhausted during the day. So you don't go by that, phraseology. You go by, how am I feeling from the sleep apnea I have? And the key, of course, is sleep apnea is fragmenting the sleep, waking you up hundreds of times during the night, and you're having changes in your oxygen.
Yeah.
Sometimes the oxygen changes are very subtle.
Yeah. It's
just the oxygen is going up and down, not necessarily a large dip, but up and down. And therefore, both of those problems, sleep fragmentation and oxygen desaturations or fluctuations, they do tremendous damage to the inner linings of your blood vessels and virtually all the organ systems of your body.
They do. Who is predisposed to having sleep apnea?
I love that question because most people think it's all about weight, obesity. And that's incorrect. Obesity is a contributor to sleep apnea. So if you lose weight, that's good. You can reduce the severity of your sleep apnea. Sleep apnea is largely, if not 100% in most cases, your upper airway. So what's going on inside your throat, your tonsils, your tongue, your soft palate, your hard palate, the way your septum. Dental arches are shaped, deviated septum, your nose as well, your turbinates. Everything to do with the upper airway is the risks for sleep apnea. But one more, in mental health, which the book is about, there's a newer theory that keeps coming up, and nobody knows if this is true or not, but it's something that's happening so commonly. Like everybody nowadays knows about PTSD, right. Post-traumatic stress disorder. It's been in the literature, it's been in the popular media for decades now. So it turns out most people with PTSD who are not doing well or not responding great to their treatments and continue to report insomnia or nightmares or just, being tired and all other symptoms, most of those people have sleep apnea.
So
and they would never know
for a
it.
second, PTSD, could you just tell us what that is?
I'm sorry. Yes. Post-traumatic stress disorder. Mm-hmm. And so that condition causes a lot of sleep fragmentation on its own. Right. People are having the nightmares, having the insomnia. But so then how did they end up with sleep apnea? And so people are wondering whether or not all this broken sleep they've suffered from destabilizes their upper airway and makes it more susceptible to collapsing and therefore ending up with sleep apnea. So it's a chicken and egg story that nobody's figured out yet. But the bottom line is, and that's why I wrote this book, Life-Saving Sleep, so many mental health patients have undiagnosed, undetected, unrecognized, unconsidered, obviously untreated sleep disordered breathing, and it's wreaking havoc on not just their sleep, but on their mental health.
Yes. We described insomnia, we described PTSD, we described insomnia and also sleep apnea, right? How do we treat these? Are there three different things? How do we treat them?
Lots of overlapping therapies. So, for example, the person who is listening to this and says, I wonder if I have a sleep breathing disorder, or I've got a family member who has a sleep breathing disorder. Yes, you have to get a sleep study, and yes, you have to go through that. But one of the things that's very interesting is that if you look at nasal breathing and whether or not you suffer from problems like congestion, runny nose, stuffiness, well, you have an immediate target that you can use to treat sleep breathing. You can use nasal sprays to treat runny nose, allergic or non-allergic, rhinitis it's called. You could use nasal sprays. You could use nasal dilators. And there's already research showing that people who use these products actually are indirectly or directly, we don't really know in terms of the research, but it's giving them benefit because their nasal breathing is better. Right. And now their sleep disordered breathing is better. And they'll say, I have better sleep quality. I have less insomnia. So that's one example that you can do early on. Obviously, if you go through all the testing, you'll end up with a dental device or a PAP machine or possibly surgery. But now when you come back to the psychological side of insomnia, you say, well, if sleep apnea and insomnia go together, which should I do first? That treatment of my breathing, or should I go down the psychological pathway? And so I'll give you one tip here that's very important. Like when anybody has the problem of insomnia, the first thing they have to ask themselves is whether or not they understand the difference between being sleepy or being tired. So most insomniacs over time forget the difference. They think it's the same thing. They say, well, when do you go to bed? Well, I just go to bed when it's time to go to bed. I say, okay, well, right, but how do you feel? And they go, well, I go to bed when I'm tired. Okay, what does that mean? Well, it means I want to go to bed. I say, no. Tell me what tired means. And they go, okay, well, it's like you're exhausted, you're tired, you want some rest. Oh, very good. You want some rest. Well, rest is different than sleep. Tell me what sleepy is. And they have to pause. Unfortunately, if you have a person who's been on hypnotic, sedative medications for a long time, they don't know what you're talking about.
Yeah.
They haven't experienced sleepiness in years, and they go, I don't know the difference. Can you explain it? I'll say, well, do you remember when you were younger, you were sitting in a lecture by a professor who was
monotone,
very, very monotone, and you got really sleepy and drowsy? Do you remember that? Do you remember sitting in church or a synagogue?
Yeah.
Do you remember going to a boring movie? And you go, oh, yeah, I remember that. Okay, well, that's sleepy. And they go, I shouldn't get into bed when I'm tired. That's right. Get into bed only when you're sleepy. And so that goes a long way down. It's a longer pathway
I
than
like that. I like that.
But that's an extremely important starting point for most insomniacs.
Yeah. That's great. I like that. So you mentioned BiPAP. When are you prescribing that?
The PAP machines are very controversial in the field of sleep medicine because most people know the word CPAP.
Right.
We stopped prescribing CPAP at our center 20 years ago, in particular because we specialize in working with mental health patients and they have anxiety. CPAP doesn't work well with people with anxiety. Bilevel means that you breathe in one pressure, but then when you breathe out, the pressure lowers. And that makes it so much easier to use a PAP machine. So when we learned that in 2005, we switched everybody over to bilevel devices and have been using them ever since. And they have all these advances. There's an auto adjusting bilevel machine. There's a machine called ASV, which is a very specialized auto bilevel. There's even more. And those machines are excellent for mental health patients, insomnia patients who have this sleep apnea problem. We try to avoid anybody getting on CPAP.
Yeah.
We try to completely avoid that because it's so intolerable when you try to breathe out against the air coming in.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard, and today we're learning about sleep health. My guest today is Dr. Barry Krakow, a board-certified internist and sleep medicine specialist who has worked in the field of sleep research and clinical sleep medicine for more than 30 years, pioneering innovative techniques for the treatment of chronic nightmares, insomnia, sleep apnea, and restless leg syndrome. He is also a professor in psychiatry and behavioral health at Mercer University School of Medicine in Georgia and an author of Life-Saving Sleep, New Horizons in Mental Health Treatment. This is a great book, I tell you, so inclusive. The cover is vibrant, and he's really talking a lot about what he's written in his book today. Doctor, I just want you to touch a little bit about nightmares.
Absolutely. Very big deal.
Yeah. Talk to me about that. Is there a difference between night terrors, nightmares, and talk to me?
So the night terror component is usually put off to a different side because it's more about you don't remember waking up screaming and yelling. And so it seems to be occurring in different stages of sleep, different times of night. It's not an uncommon condition. It's very important to treat, but you absolutely have to go to a sleep center to evaluate a night terror, whereas a nightmare problem is bad dreams that wake you up, disturbing dreams. So you can make the diagnosis yourself. There's people out there that know treatments. We have on my website, barrykrakowmd.com, we have a couple of resources about treating nightmares because nightmares actually, believe it or not, are treatable. Most people think, well, don't you go to the psychotherapist and they treat you for something that's causing the nightmare? And that's exactly the way things were 30 years ago. You either got a pill or psychotherapy. What we learned in this initial research and carried it forward is that there is a cognitive imagery technique called imagery rehearsal therapy that we pioneered and which can treat chronic nightmares. No medication, no psychotherapy. And it has to do with the way the mind actually works. In fact, I'll give you just the best example. Most people who go through a traumatic life experience will absolutely experience nightmares in the first 30 days. Just think 9/11. After 9/11, everybody was talking about their bad dreams. But 30 days later, or 90 days later, more than 90% of those individuals will say, I don't have bad dreams anymore. The other 10%, unfortunately, or 20% in some cases, will get PTSD. Nightmares is actually a signal that this process is not being processed in your mind and your heart and your body. So it's natural for nightmares to go away. When they don't, we have what's called a nightmare disorder. And that nightmare disorder takes on a life of its own, which is why in the years past, when people tried psychotherapy and pills, it didn't work. Now we know the nightmare itself has to be treated. And the best treatment out there is the one that we pioneered back in the late 1980s called imagery rehearsal therapy, where a person learns to look at their nightmares while they're awake and actually reflect about the images that are bothering them. And then they work on trying to change those images and rehearsing new images. This is all done while you're awake, not while you're asleep. But it turns out when you work on new dream images that you're creating while you're awake, they will influence what happens to you at night. It's a very powerful technique. There's about, I think, 15 to 20 other research groups around the world that have all published variations of IRT, it's called. Everybody shows the exact same results, that not only does IRT decrease nightmares, but by decreasing the nightmares, you decrease PTSD symptoms.
That's interesting. What about somnambulism? Why does that occur?
These are called the parasomnias, sleep talking, the night terrors you mentioned. It can be thrashing around in bed. These are something that are mostly caused by a sleep breathing disorder. And if you think about the logic of it, it makes perfect sense. If you can't breathe, you're going to do everything you can to move your body to get into a position to be able to breathe. And so lots of research has been published on this years ago showing that most people with a night terror or sleepwalking or even sleep talking have sleep apnea. We're talking about 80% or 90%. And so when they get their sleep apnea treated, they go, hey, what happened to my sleep talking? What happened to my sleepwalking? It's all gone. Now, there's other cases of it, and those are, particularly sleepwalking, can be very serious.
Yeah.
Because if you sleepwalk and you injure yourself,
safety.
It's like, do not pass go, do not collect $200, go directly to the sleep center, because it has to be evaluated, because that can lead to serious injury.
And what is that website again?
BarryKrakowMD.com.
This has been very, very interesting, and we have to get you back because this is a lot of information that I'm very interested in myself. But for now, we want to thank you for being here, Dr. Barry Krakow, a board-certified internist and sleep medicine specialist who has worked in the field of sleep research and sleep medicine for more than 30 years, a professor of psychiatry and behavioral health at Mercer University School of Medicine in Georgia, and the author of Life-Saving Sleep, New Horizons in Mental Health Treatment. You got to get the book. We thank you for giving us this important information, and we hope you continue to stay healthy and keep doing the great work that you're doing.
Good talking with you, Jeanine. Thank you for the time.
This is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the nursing department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.